Welcome, and thank you for joining this webinar in the COVID-19 and Humanitarian Settings, Exploring the Controversial Issue series, produced by the Ready Initiative, the Johns Hopkins Center for Medicine, and the Geneva. Encourage participants using the Q&A feature directly in Zoom. Some of these questions will be addressed in the Q&A discussion. Access to today's recording will be available after the webinar at readyinitiative.org and on the websites of the three universities. We also encourage you to the COVID-19 Humanitarian platform at www.covid19humanitarian.com, which curates, analyzes, and interprets guidelines and interventions being implemented in a variety of humanitarian settings to prepare for, respond, and adapt to COVID-19. The platform also has a COVID-19 humanitarian tracker with real-time data for affected countries. It is now my pleasure to introduce our moderator for today, Professor of Practice at the Johns Hopkins Bloomberg School of Public Health and Director of the Johns Hopkins Center for Humanitarian Health, Dr. Paul Spiegel.
Hi, good morning, afternoon, evening, everyone, and thank you, Ryan, for introducing and Ready for helping us to put this together. So we're thrilled to have all of you today. The topic is, why is COVID-19 not transmitting in humanitarian settings as expected, or is it? We currently really don't have a good understanding of how the novel coronavirus is being transmitted in these settings and what are the effects of COVID-19. It was assumed that given crowded conditions, poor hygiene, and baseline levels of health, that non-pharmaceutical interventions would be more difficult to implement, and that hospitals with limited to no ICU capacity would be quickly overwhelmed. However, this does not appear to be happening, or at least has not been reported in such a way. So we're here to discuss these questions. We're going to start now with a very, very brief poll. So Ryan, if you would please put the poll on. And then if the participants can please just answer either agree, not agree, don't agree, or unsure. And then we're going to do this again after we speak. So please go ahead and do that and submit your questions. I'm sorry, submit your answers. And while we're doing that, I'll just briefly explain. So this is going to be, it really is going to be a panel and a discussion. We're not going to have PowerPoints. What we've done is I'll introduce our panelists sequentially, just a very brief introduction of who they are, give a brief context, and then answer some, and ask them some questions. Each of them will have 5 minutes to respond. And then once that's done, we will interact amongst ourselves for about 8 or so minutes. And then during this time, we'll be taking questions and Kiara will be collating them, and then I'll be asking the panelists. So Ryan, I don't know if you are able to, I haven't seen yet to show the results. Okay, so at the beginning of this, 22% agree that it's high, 23% disagree, and 54% are unsure. And we will be curious at the end to see if that changes at all. So I'm going to start now, and we're going to start off with Altaf Musani, who is currently the WHO representative for Yemen. It's been a pleasure. I've known Altaf for many, many years. He's worked for WHO in humanitarian emergencies in numerous countries, including Afghanistan, Iraq. He was the WHO representative in Iraq, Pakistan, and of course now Yemen since 1999. And he previously worked with IMC in the field and CDC. So Altaf, according to the WHO Yemen dashboard, as of yesterday, there were 2,056 confirmed cases and 597 deaths in Yemen. Yet it's been reported that gravediggers in Aden and other cities have been overwhelmed this summer. And Francesco Cecchi of London School of Hygiene and Tropical Medicine testified in the UK, and I quote, "The anecdotal reports we're getting inside Yemen are pretty consistent that the epidemic has, quote unquote, passed. There was a peak in May and June across Yemen where hospitalization facilities were being overwhelmed. That's no longer the case." So to start with, Altaf, the question is I have for you is number one, what data are actually being collected in Yemen, and how confident are you in its quality and representativeness? And then finally, what would need to be done better to get a better grip or understanding of what's happening with COVID in Yemen? Over to you.
Thank you, Paul, and it's a pleasure to see you as well as the other panelists. Let me just start by making one or two introductory remarks that Yemen, uniquely, like other humanitarian situations, was very bad prior to COVID. So our benchmark of measure is obviously before COVID and now with COVID. Unlike other humanitarian settings, Yemen happens to be the world's largest humanitarian operation, not only in terms of the humanitarian footprint, but more so the humanitarian needs in Yemen. And this is roughly 24 million Yemenis that require some form of assistance collectively. And so we were already heading into an environment of COVID where we were very dire in terms of our operational footprint, our ability to provide direct access for food, water, and healthcare. And so the COVID overlay was a deep concern. And in fact, Mark Lowcock, the ERC of OCHA, had advocated this very loudly during several Security Council briefs, saying that no more where in a country such as Yemen, this will be the virus of COVID-19 be widely spread, deadlier consequences, and impact humanitarians' capability, and more so the health authorities, to be able to respond. And so to that effect, the data part of our ability to understand what COVID would do, we obviously embarked on several modelers to be able to give us some planning horizons. This was not only used for planning purposes, but more so to piece together a very fragmented plan presented by the different authorities throughout the country to say, where do we think our operational capabilities for response are? And I think, as you cited very clearly, when you look at our dashboard, and reminding everybody that the obligation to report, it relies on the member states. Through the international health regulations, we depend on health authorities to be able to give us that data. And you're absolutely right. That 2,000 plus data represents a number of issues. One, a grossly underestimation of what's really happened with COVID-19. Two, it's a segment of the COVID cases which are targeting the severe and critical. Three, it is more of a reflection of the data that is being pulled disproportionately from the south rather than the north. And absolutely, I mean, we've relied heavily not only on the data parameters to see where we are on the curve, but more so to be able to guide the population. It's really important for us to be able to invoke some type of behavioral change, whether it's the protective measures against the populations use, the mask wearing, the physical distancing, or actually seeking healthcare. I mean, again, and I revert back to pre-COVID times when health-seeking behavior was very different throughout the country. So you're absolutely right. We've used additional measures such as social media. We've talked to the healthcare workforce. We've looked at hospital admission data to be able to piece together our data issues.
Okay, thank you. What other, so do you have a different, in terms of your data currently, are there other, beyond just on the dashboard, do you have other data to show that there has been a significant amount of at least transmission in Yemen?
So being the largest humanitarian operation, there are several data parameters that we use to piece together the humanitarian environment. And smart surveys, nutritional surveys, hospital admission. A lot of it is by proxy. We do collect primary data, but the difficulty by and large has been for the authorities to report directly COVID, critical, severe, asymptomatic, mild, and moderate. So we know that we're very far off the curve. And one of the things that we're looking forward to going into our preparations for waves 2 and 3 is how do we now recenter those data parameters? Go beyond the south from the critical and the severe cases, and we're working with several institutions through seroprevalence coverage surveys, as well as direct targeting of the mild and moderate cases to really look at caseloads that might be attributed. And I think co-infection comorbidity patterns are critical in Yemen. You cited very clearly that there was high case fatality rate. We didn't know that was attributed to dengue, malaria. In the initial days in the south, there was a lot of confusion of a viral hemorrhagic fever being the plague, and then obviously the plague overshadowing what was really happening with COVID. So we don't really have new systems online, but we are going to try and really push the authorities to take existing surveillance, existing hospital administration data. But again, it's important to understand that this is all happening within the context, not only humanitarian environment, but the active war. And so we've gone from 30 to 45 front lines within a 6-month period, and it's very difficult to collect that type of data on front lines.
Thank you. We won't have time now, but in the further discussion, I'd like to hear a little bit about your plan or what's feasible given the political complications and issues in trying to collect data from the north, or at least get data from the north. So we're going to now move to Dr. Sandra Harless, who's a senior public health officer at the United Nations High Commissioner for Refugees. She's currently in Cox's Bazar in Bangladesh. Sandra has more than 18 years of experience working as a public health specialist in many different countries in Africa, Asia, and Europe. And she's worked with UNHCR for the last 6 years, as I mentioned, currently in Bangladesh, where she's the health and nutrition team leader as the senior public health officer. Sandra, wonderful to have you. Given your experience in Cox's Bazar, I think at least over the last 2 years, if I'm not mistaken, I'd like to first ask you about the Rohingya situation, but then move on to some other refugee settings globally. So as of yesterday, just like with Yemen, I went on to the WHO dashboard, and they said that it reported there were 12,143 tests amongst the Rohingya, but only 277 confirmed and 8 deaths. Now this is a test positivity rate of 2.3% for the refugees, compared with 14% in the surrounding host populations in Cox's Bazar. And similarly, the infection mortality rate is only 0.07% for refugees, but more than doubled, 0.2% for the host populations. Why do you believe this is the case? And what do you actually believe is happening in these refugee camps with respect to COVID transmission and death, number one? And then number two is beyond Bangladesh. Again, to many of our surprise, it doesn't appear that COVID in both refugee settings outside and inside of camps has been having a major, at least we're not aware of the transmission and certainly numbers of deaths. So what do you believe are some of the possible reasons for these no numbers of reported cases and deaths? Over to you, thank you.
Thank you very much, Paul, and thanks for having me here. I hope you can hear me clearly. We just have a massive rain shower starting here, so it might be a little bit noisy in the background. Apologies for that. That's Cox's Bazar realities. So let me start with the situation in the Rohingya refugee camps. So with regards to the different positivity rates that you mentioned, when we compare the access to testing in the camps to the host community, it is comparatively easier in the camps. We do have 22 testing sites there, and in the host community, the testing is more concentrated in larger towns. And in addition, we also use in the camps a sentinel testing approach. So we don't necessarily test only those that strictly meet the WHO case definitions, but we really look also for a wider segment of the population to see, especially if there are many asymptomatic cases or mild cases that might have otherwise gone unnoticed. So when we look at the actual case fatality rates among the refugees in the host community, it is a bit higher in the refugee camps than it is in the surrounding host communities. But as you rightly said, we have very few cases so far in the camps and few mortalities. So that might also change over time. What I think is very likely that the actual number of persons being infected with COVID in the camps is higher than what is being recorded. We had, especially in the early phase, rumors around COVID and around the Sahari ITCs that prevented many people from seeking testing and care. So this has been reversed after a lot of interventions, a lot of awareness raising campaigns and door-to-door visits. But we still think that not everybody is coming forward who needs testing. And also the referral to the testing sites is still an area that can be further improved. What we have seen in the last couple of weeks, in September especially, we have seen a rise in ARI patients for general consultations. That is about 40% more ARI cases than we had in the same time last year. And at the same time, we had also seen an increase in COVID-confirmed patients. So when the ARI consultations peaked, we also saw then the COVID cases going down. So it's quite possible that this could have been a wave of COVID infections, with many cases being mild and asymptomatic, but we just don't have a confirmation. So there is a seroprevalence study planned by WHO within a month that will hopefully give us more clarity on what actually the situation is and where we are in the epidemic. Talking about mortalities, we do have quite a robust system of community-based surveillance that covers all the camps. We have around 1,500 CHWs that are dedicated, that have dedicated reporting areas and report weekly. So we did see a bit of an increase in mortalities in June. We didn't see an increase now in September. And when we compare the rates to last year, they are actually quite comparable. We don't really see significantly more mortalities in the camps. There have been some reports that suggested that deaths might be hidden in the community in large numbers. And we did do additional investigations with WHO colleagues to dig further in our data. And I think we all do recognize that the community-based systems do have their limitations, and that there may be cases that are hidden in the community, but we also believe that we would have seen, if there would have been a large increase in hidden deaths, that we would have picked those up through the various other avenues for reporting. We also did not see any significant numbers of severe forms of COVID, which we would expect. If there is a high number of mortalities, we would expect that at least a certain percentage of the persons would come forward to seek treatment, even if not everybody would perhaps seek care in the facilities. So in summary, on the Rohingya refugees, I do believe that there are more cases in the community, but also that many are mild and asymptomatic cases actually. And what you mentioned in other refugee operations, we also see similar low rates of reported cases and deaths. There are a few factors that the Rohingya refugee camps and other refugee camps worldwide have in common that might contribute to lower infection and mortality rates. The camps, for one, are tightly controlled areas, usually with tightly controlled access, and that has been further strengthened and also restricted with COVID, with the COVID infection starting. So UNHCR, in cooperation with especially WHO and many other health partners, we do have established surveillance systems in the camps. We have early alerts and alert investigations, contact tracing, isolation and quarantine facilities, in combination with awareness campaigns and physical distancing measures. And I think we have to recognize that in a closed setting like a camp, this is easier to implement than, let's say, perhaps a slum area where infections spread more quickly and people go easily in and out. The camps also have, in that sense, the advantage that services are provided in the camp, healthcare, food services. So there is less mixing of people going in and out. In the same time, we also have to recognize that the testing really varies. I think in Cox's Bazar, we're in a lucky position that we do have good PCR capacities. That's not the same necessarily in other refugee operations. And when we look, for example, in the South Sudanese refugees in Ethiopia, there is much less testing being done among the refugees than among the host communities. So these are often perceptions that refugees have better access, but it's really varies a lot from different camp settings to camp settings. And perhaps just a last factor to mention, refugee populations also tend to be younger populations with less comorbidities, especially in the early phases of displacement, which could also be a factor on why we see less cases or less severe forms and mortalities in the camps. So I'll stop here, but I'm more than happy to take questions in the end. Thank you.
Thank you, Sandra. Yeah, it is indeed interesting to see, even though we may not know yet until we have serial surveys, the actual amount of transmission, the death rates are really, really low in these settings and lower than would have been surmised, let's say, compared to other settings, which brings me to Sean Truelove. So Dr. Sean Truelove is an assistant scientist in the Department of International Health at Johns Hopkins Bloomberg School of Public Health. And Sean's work focuses on infectious disease epidemiology and disease dynamics and modeling. As part of the Center for Humanitarian Health, he's co-led an initiative to provide SARS-CoV-2 modeling and epidemiology support to humanitarian partners, including UNHCR, OCHA, and MSF. So Sean, thank you, of course, for being here. You've heard, and I know you've been looking particularly in the Rohingya setting. But what we're seeing is that early on, it was noted that the proportions of deaths in the models that came out, the transmission was seen to be very high, and the proportion of deaths was lower in these settings because of what Sandra mentioned, mostly very low demographic, the high percentage of children and lower percentage of people over 60. Yet still, the models did, I think, understandably predict a significant increase in excess mortality that we don't appear to be seeing. Why do you believe this is the case? And this was, if I may say, this was similar in other refugee and IDP settings. So why do you believe this is the case? And what type of information do you believe is needed to make models more relevant to actors in the field?
Thanks, Paul. Thanks, everyone. It's really great to be here and talk about all this. So I guess this has been a real surprise kind of across the board. I guess it's a happy surprise. We did expect much more severe outcomes among these settings, and not just humanitarian settings, but also among LMICs, including many countries in Africa. But I think generally speaking, this has kind of occurred through a combination of an overestimation of severe outcomes and potentially an overestimation of the amount of transmission that would occur, as well as the substantial underreporting and underdetection in these settings. And it has made it appear that these populations have been largely spared, though I don't know that that's necessarily the case in terms of actual transmission and infection. And so from the side of modeling and our early projections, I guess it's important to note that these were really early on. We were using data that were being collected and provided through populations like China, some European populations that were not necessarily representative of these populations. And so a lot of our understanding and estimates early on of how severe an individual case could be and what the probability of them becoming a severe case or becoming hospitalized or dying really came from those populations. But it also, it came from very small studies and small sets of people for which we really didn't have a full picture. We were relying heavily on these populations of very few individuals where we were hoping every single person was tested and tested appropriately via RT-PCR, but that has its limitations. Particularly because it doesn't tell us everything about the whole history of an individual's infection, where an individual may not test positive via RT-PCR early in their infection or late in their infection. And so this really gave us, I think, an overestimate of how severe infection might be in a lot of these populations. And then that resulted in us overestimating the probability of death or of hospitalization in these humanitarian populations. So I think that that really contributed to some of this over projection and overestimation of the impact in these populations, but that's not all of it. Really, a large part of it is that we just don't have enough information and consistent information about who is being infected through testing. And some of the testing has been inconsistent. And so that's made it difficult from the perspective of modeling to try to capture some of these trends and these behaviors in order to really represent what's happened or what's been happening. And so while I agree with Sandra that the severity has not been seen, I think it's unlikely that transmission has really been controlled in these settings. We know that, and she mentioned slums in India and other places, where seroprevalence rates have been extremely high, where we thought previously that transmission was not occurring. And it's very possibly that this is a similar situation in these refugee settings, where there's a lot of transmission occurring, but because of the amount of asymptomatic and very low severity, we're just not seeing it. People aren't seeking care. And really, I think what we need to, like for us from the side of modeling, to improve this for the future, we really need to think carefully about how to deal with sparse data like this in these contexts. And this is not a new problem, but I think it brings to light just how early on in situations like this, we need to be careful and consistent with how we collect these data and report these data.
Sean, let me ask you briefly, and then we'll move to Maria, but why, if there has been possibly, and I would agree that there'd be high transmission in many of these settings, why are we seeing so few severe cases, at least being reported severe cases, and limited deaths?
So yeah, and I think it's a combination of things, right? I think, there's some anecdotal, qualitative sources of data, such as among the Rohingya population, the ACAPS report that came out, that indicate that there has been almost a systematic effort on the part of the population there to not report and not seek care or testing by the Rohingya for COVID-19 due to some of the issues there. And so that may be contributing to it. And I think, as you mentioned about Yemen, with burials being overwhelming, the cemeteries there. So there may be deaths occurring that just aren't being reported and captured. But again, I also think that we really thought that severity was going to be higher in these populations. And that's really what has led to a lot of the projections being high. Whereas we're seeing from some of these, I think, so there was a recent report from Bangladesh, and they found that among those people who were tested positive for current infection, 82% of them were asymptomatic. And so it may be that we have a differential rate of asymptomatic infection among these populations as well, that we just, we didn't see among populations in the US, Europe, and China early on. And so when we took those data and we took those estimates and applied them, that really led us to thinking we were going to have a different situation than we ended up having.
Okay, thank you. A lot to discuss. Lots of other potential factors as well that maybe will come up in our discussion, and I'm doing my best to read a little bit what others are putting into the chat and the Q&A. So we'll move now to Dr. Maria van Kerkhove, who is WHO's COVID-19 technical lead and head of emerging diseases and zoonoses at WHO in Geneva. Maria is an infectious disease epidemiologist, and she has a background in high threat pathogens and specializes in emerging infectious diseases. So Maria, again, like everyone, thank you for coming. For a variety of reasons that the panelists have mentioned, and even more that will be discussed, we really don't have a good idea, I think, in humanitarian settings of what both the spread and the effects of COVID-19. And one of the only ways to do this will be likely through sero surveys. My understanding is that there have been numerous sero surveys undertaken globally thus far, but of varying quality. Some have occurred in fragile settings, such as Libya and Afghanistan. And we've also been looking, as Sean and Sandra mentioned, at some of the sero surveys that have occurred in slums because of the high density and relative poverty may be similar to a refugee or IDP camp setting. So, for example, one of the studies, and I don't know the quality of this yet, but some of the slums in Mumbai in July were found to have a 57% seroprevalence amongst slum dwellers, compared to 16% amongst the non-slum dwellers. And then just, I think, yesterday or the day before, an IEDCR survey in Dhaka in Bangladesh was released that found 45% of people were seropositive in the capital. Again, at this point, I can't comment on the quality of it. But WHO talked recently about an average globally of about 10% of people that have antibodies for the virus. So my question to you is, well, many studies have not yet been published, and as we mentioned, varying quality. Can you discuss some of the general findings of the higher quality seroprevalence surveys and how they may or not be applicable in humanitarian contexts? And then finally, as Sandra mentioned, there is going to be a sero survey led by WHO amongst the Rohingya, and I think Cox's Bazar itself, surrounding coastal populations in the next few months. But are you aware of any other sero surveys that are planned in humanitarian settings?
Thanks, Paul, and hello to everybody. That's quite a few questions in one, but yes, indeed, seroprevalence studies are very helpful to help us understand the extent of infection in populations as measured by antibodies. And I think everybody is well aware that in the beginning of any epidemic, any pandemic, our surveillance tends to focus on severe patients and is based on PCR testing. And that's typical. It's what one would expect, because these are the individuals who show up at healthcare, who are identified and who are tested. And as testing capacity increases, as surveillance expands, we tend to pick up people on the more mild end of the spectrum, but it doesn't capture the full extent of infection. So we use seroepidemiology, and those of us in infectious disease epidemiology have been trying to standardize the approach for seroepidemiology for more than a decade, starting with influenza, where we need these types of global estimates to be able to compare countries using similar methodologies. And we have outlined a number of protocols to standardize the approach in terms of the methods that are used to collect data. We have 6 protocols that are available to do this. Some of these are population-based studies. And these are the studies that will be carried out in Bangladesh and also in Yemen in the coming months. And so that is something, we don't have the results of those yet, but this is using a standardized approach. This is using a similar assay, so we can have almost apples to apples comparison. Having said that, WHO is also tracking all of the seroepidemiology studies that are occurring globally. And so there are more than 158 studies that have results to date, 10 months into a pandemic, which is pretty phenomenal, given that we're in a global pandemic, given that people are able to carry these out. They are of varying quality, these studies. Many of them are preprint, so they have not gone through peer review. About 70 of them have actually gone through peer review, and then there are a number of government reports as well. They tend to focus on different populations. Some of them are population-based seroprevalence studies. Some of them are focused on essential workers, health workers, frontline workers. Some are focused on high-intensity transmission areas. Some are focused on slums, as you point out. Very few are occurring in humanitarian settings at the moment, but we're trying to change that, and we're trying to work with countries to be able to do that. And you said in your intro that these are WHO-led studies, and in fact, these are country-led studies. WHO is supporting these studies to be conducted by researchers, by ministries, by partners in country to build that research capacity, and so that they own those results, and those results get fed into the response itself. What we know globally about the studies, this is a huge overgeneralization because of all the limitations with the results that we have so far, the assays that are used, the timing of the data collection, the populations under study. And out of these 158 studies, the vast majority have seroprevalence results under 10%, some well under 10%. There are exceptions. The exceptions are frontline workers, health workers, where we see seroprevalence in the 20–25%. There are some studies in slums, in areas in Argentina, in India, finding above 50%. Many of these are using RDTs, so rapid diagnostic antibody tests. The quality of those tests are not great. They give an indication. They do help us understand, they give an indication. But what we would ideally like are neutralizing antibody tests, which of course you need a specialized lab to be able to do so. There are some higher performing ELISA tests that can be done in many countries, and that's the ones WHO is focusing on and actually providing those tests to the countries that we are supporting. So there's varying range in terms of what we understand. But this makes sense if you think about it, because this virus needs close contact to spread. This tells us that in situations, if the virus enters, and I think this is the critical factor, and Sandra pointed this out, in the settings where you have closed settings, or there's limited mixing, limited introduction, if the virus were to enter into that situation and spread like wildfire, it's very, very difficult to control. And you may have younger populations, you may have fewer underlying conditions, but it is very difficult to hide deaths. If you have individuals who have underlying conditions, if you have individuals who are above 60 years old, we know globally that people have a higher risk of death if you're in those categories. So I think there's a number of things that are happening. As you pointed out, we do have the studies. These are done under our heading of these called Unity studies, which are using the WHO core protocols. We're providing technical support, operational support, financial support to carry these out using a standardized approach. And in Yemen and in Cox's Bazar, it'll be a population-based serosurvey, which will have a few thousand individuals enrolled in these and using the assays that we provide. We don't have the results of those yet. So, you know, your answer to your question of do we know, we really need to wait for those results. But I do think globally, we do see that the range of the detected to unrecognized is about 1 to 10, 1 to 12. So for every case that we detect for PCR, we're missing about 10 or 12 unrecognized. And I don't say asymptomatic, and I do that on purpose, because a seroprevalent, somebody who has antibodies and wasn't detected through normal surveillance doesn't necessarily mean they were asymptomatic. It means they were unrecognized. And I do think we have a large proportion of people who may be asymptomatic, but I hesitate to even use the word, because most of the time when I hear asymptomatic, you ask for a definition, they say, well, not COVID-specific symptoms. I say, well, what do you use for COVID-specific symptoms? Because they range so broadly. Fever, cough, shortness of breath. But we know many people have very, very mild symptoms. So I think we do need to be careful about the use of the word asymptomatic. And if you look across the Middle East, if you look at just surveillance using PCR, there's large proportions that are mild or asymptomatic, but that has to do with screening. So I think, you know, there are certainly unrecognized cases. I think seroepidemiology is an incredible tool that can help us really understand the spread of this virus. But in situations where you have close proximity to one another, the key for us is to prevent the introduction. And if it is introduced, to make sure you have those systems in place to deal with it. I am struck by the capabilities and the resilience of populations in Yemen and in Cox's Bazar. I mean, Sandra outlined and Altaf outlined all of the systems that are in place for surveillance, for case detection, for seeking care, for testing services, which many high-income countries are not actually able to do. So I do think that the systems that are in place are serving them well. I think there's a lot more that we need to be able to do. But let's see what comes out from these serosurveys to really get the answer to see how much circulation is happening undetected. Thanks.
Great, thank you. We have around 21 minutes or so left. So what I'm going to do is, Chiara's feeding me some of these questions. I'm going to actually go back to you, Maria, and ask two questions, both from the Q&A. One is, are there any plans to combine the serosurveys with the mortality surveys to be able to better understand the mortality? And then related to that, I wonder if you could, what I understand, talk about the issue of in some settings, in similar settings, you have high seroprevalence, but in where you'd expect to have a high-ish seroprevalence, but in a similar setting, in a similar country or region, you have low seroprevalence. So there doesn't seem to be much concordance. Can you discuss that and why that may be?
Yes, so for the first answer, or the first question, plans to combine serosurveys with mortality surveys, yes, as much as we can. So what we are trying to do is through our the Unity studies that we're doing, we would like to be able to combine the results, pool the results from the studies that are population-based serosurveys. We also have serosurveys focused on health workers, on household transmission studies, on schools. And so if we are able, with the permission of the principal investigators, because the ownership of these studies is the countries themselves, to be able to pool those together with mortality surveys, I think that would be very, very helpful for us to really estimate the infection fatality ratio and look at further estimates. There are a couple of good studies that are out already. There's one, and I'm forgetting the authors, I should know this if I'm going to report on it. I think it's a preprint that looked at 45 mortality surveys and 15 seroprevalence surveys. I believe London School was involved in this, looking at IFR, infection fatality ratio, and it varies drastically because it depends on how this outbreak unfolded in each country. For example, in some countries that had high impacts in long-term living facilities, where you had tremendous and really devastating outbreaks in older living facilities, the mortality was much higher. There's a dramatic increase in IFR by age, and that is a consistent finding across countries. But yes, the long-winded answer to that first question is yes, and we will work on that. The second question around the discordance between seroprevalence results, even within country, is common. And in fact, we are tracking this ourselves, and we're looking at all of these studies that are coming out, and it is quite discordant. A lot of it has to do with when, which population was sampled, when the population was sampled. And most of the studies where we have results, the samples come from April, May, and June. There are actually very few that are collecting, well, very few that have results where the samples are more recent. Our ideal study that we would like are longitudinal studies, which follow the same individuals over time. And second best are cross-sectional serial sampling of the same populations, so that we can look at seroprevalence over time within these populations. This is absolutely critical. Almost all of the studies that are out are snapshots. And so this is really important and gives us a clue. It tells us that the majority of the world's population remains susceptible. And that is the point that we have consistently been making in our press statements and in our public statements, and that remains true. But we do need to track this over time. But I think it has to do with the way the studies are done, the assays that are used. There are hundreds of rapid tests on the market. Many of them are very poor quality. And so we need to have a better approach of the tests that are actually used, not to discredit the studies that are being done, because I don't want to imply that at all. But I do think we need to recognize that there are some limitations with the available results that we have to date.
Great, thank you. I'm going to move to, well, actually all three then. First starting with Althoff, and then Sandra, and then Sean. I'm going to combine some of the questions. So Althoff, there's one question, and you hinted at it already, but in places like Yemen, is COVID considered amongst the population a serious threat relative to famine and all the other major challenges they have, number one? And then number two is relating to, and I don't know if this will be sensitive for you to talk about, but the politics where you have, as you mentioned, you're not getting results in the north. And this is not uncommon that in many parts of the world, some governments may not wish to record what they are seeing for various reasons. Actually, let's start with that, and then I'll ask Sean and Sandra another question. Over to you.
Sure, thanks, Paul. So to your point, where in terms of the population themselves, we obviously haven't seen the behavioral change. But obviously, when we looked at some of the surveys that we've done through the C4D, using UNICEF as a vehicle to be able to understand what is the retention of COVID-19, we've reached 26 million people. And what is clear is 26 million people within Yemen understand that COVID-19 is a public health problem. Where we don't see the reaction or the change is in their behavior. And whether that behavior is earlier onset presentation to the health system, because part of that survey looked at the fact that they have a lack of confidence within the health system. And a lot of this reverts prior to COVID-19. In addition to it is what you alluded to earlier, is the authorities declaring and reporting. And I think I want to make that distinction because there is a bit of a misnomer that, again, WHO serves as a repository for the declaring and the reporting. That is something that is reported through us through the international health regulations. And you see, when we talk Yemen, it's a very fragmented picture, north versus south. The southern authorities, the internationally recognized government, are consistent in reporting, but I think as Maria alluded to, those are the critical and severe cases. Those are the individuals that manage to come into the health system. Of course, is connected to our testing capability. One of the critical factors in Yemen-wide rollout of COVID-19 was the capability to have sufficient sufficient PCR capabilities throughout the country to be able to capture even beyond the critical and the severe cases. But to your point, in terms of the reporting and the leadership, I mean, we have been very consistent as an institution and as the humanitarians wide, saying that there is an obligation for you to report. And it's just not a box ticking exercise. I think we've all alluded to the fact, and Sean stressed this, that these numbers are critical for us to be able to drive where we are on the outbreak. You know, are we on the curve? Are we declining? Is there severity? I see there's questions of saying, is Yemen an exception? Number two is the population. The population feed off these numbers. And when leadership tells you, you have a problem, then they're more likely to be able to take measures to protect themselves, their families, and their communities. And we did not see that. So the application of suppression measures, the application of mitigation measures, even the awareness was not there. And again, going into the fall, where there's going to be high seasonality of influenza, and we know that, as you alluded to, pre-famine conditions, reminding everybody in 2017, Yemen had the world's largest recorded cholera outbreak in the world, more than 1.1 suspected cases of cholera. Now, we've gone very far from that and contained that outbreak, but again, cholera, very different from COVID-19. But the mix, to your point, with dengue, malaria, cholera, influenza, the population continued to have these exogenous shocks whereby they're saying, yet again, another infectious disease. And you then complement this with their other public health problems. They look to the leadership, they look to the health system to provide them answers. And this goes to the nature of the fact that it is a complex situation. It is an active zone of conflict. And then, of course, I think what Sean alluded to, there are these small populations that have been shielded. And I think Sandra said this as well. Refugees, those internally displaced, and those migrants did benefit from the shielding protocol. The question is, how long can we sustain that? And so Yemen is again, I say, a deep concern because of lack of robust systems. Again, Maria mentioned this. In the case of Yemen, birth and death takes place at home. To complement that, there's no formal registries. And so to say it's complex is to do injustice to Yemen. And I think what we try to look at is prioritize the priorities, really just address the high course of morbidity, and then try and create these solutions around that, whether it's yet another cholera outbreak, whether it's pre-famine conditions, whether it's food insecurity, and really just work with the authorities and the humanitarians large. And I think this is a credit to the humanitarian community that they are holding and lifting Yemen to be able to make sure that they don't fall into famine-like conditions, to make sure that the health system, although 50% not functioning, wherever parts are available, are offering services. Is it enough? By no means stretch of the imagination. And I think we continue to push the authorities even beyond the health sector. I think our Director General has been very a strong advocate for this, and very clear to say that this is beyond the health system issue. This requires leadership at its core levels to be able to say, we have a public health problem. And we know that across Yemen, the concern was the health system wasn't robust enough to take on the critical and the severe cases. The heavy need for ventilation, and then our change in therapy to oxygen support, as well as the healthcare workforce didn't have the capacity to deal with this new disease. So, I paint a very bleak picture, and I think going to your question about models and where we're going, you have to take COVID-19 into consideration with all the other public health and humanitarian needs that are in country, evoke some formal leadership across Yemen in order for us to be able to tackle this in the fall.
Okay, thank you. Moving to Sandra, and this question could also be for Yemen and many other countries, but there's a question from some of the participants about deprioritizing, in a way, COVID-19, or what is suffering because we are focusing on COVID-19. But given the situation that, if it is true that we are not seeing, maybe we're seeing transmission, but not serious morbidity and deaths, are we putting too much emphasis on interventions for COVID-19, and are other aspects such as maternal child health, mental health, actually being put more at risk because of the focus on COVID-19. Number one. And number two is, I think both you and then Maria also said that it's unlikely that you would have missed, because of the community surveillance, that you would have missed an increase in deaths. As Sean was saying in the ACAP survey, that they have been hidden. Is that a possible? Do you feel that are you confident that you're not missing very many deaths, and that therefore there really has not been an increase in mortality due to COVID in these camps? Over to you.
Thank you, Paul. So in terms of deprioritization of other activities, we did have a lockdown of the camps, and it was across different sectors. So this affected, let's say, shelter, for example. No, we had the middle of the rainy season, and normally the rainy season is when you want to repair the shelters before and ongoing. So we had, for all the sectors, we developed together with the different sectors and with the government what are really critical activities, life-saving activities, to make sure that they can continue. So in terms of, if you stick with shelter, this means, for example, we did blanket distributions with plastic sheets, and we replaced the houses that were totally damaged, but then had to rely on refugees to take on more of the burden for repairing things themselves. And what we have seen in terms, when it comes to healthcare and deprioritizing healthcare, we have seen a decrease in consultations in general. There was not so much a matter of deprioritization from the health sector side, but it was a community perception that communities were very fearful, especially in the beginning, that health facilities are places where you can get infected with COVID. There was also the perception that if you are identified with COVID in these facilities, you will be taken away. There were a lot of rumors, including that people will not come back, that people may be even killed. And so this was much more a factor impacting actually health seeking and limiting. So it was people limiting it themselves. So it wasn't that the actively reduced services, all the preventive services, everything stayed open in healthcare, the SRH services. The vaccination services stopped for 2 months, but that's the only one that was really put on hold by the government. So we had to do a lot of trust building activities with the community. And I found it quite interesting what Altaf just said, also when it comes to behavior change and how to overcome all these rumors and hurdles. So we had shifted from, I would say, where are we now, August onwards, to really emphasize, once this first wave of education on what is COVID, what are the signs and symptoms, infection prevention measures that you can take at home, then towards restarting this, promoting access to SRH services especially. And we do see this coming up. What I found encouraging is that when we look at facility-based deliveries, this is one of the indicators that we feared the most would drop. That hovered constantly around the same value of 55% throughout the years. Where we did see a lot of drops was where people deprioritized antenatal care, EPI, postnatal care. But these are slowly picking up again. But it does take a lot of time to re-emphasize this. And what Altaf said, I found really interesting, this behavior change. We found really that people know. They know quite quickly, but I think all of us kind of expected people will change their behavior quite quickly. And I think we expect too much in general from populations. And I think this is not only here, but also in European countries. I think we don't just tell people once, this is what you should do, and then we all adjust our behavior. If this would be the case, none of us would be smoking, for example. And I think this is one of the lessons we had, that we kind of expect. We tell people you should wear a mask, you should distance yourself, you shouldn't go and group in larger groups. This takes a lot of time to trickle down, and we have seen these changes coming on. We have seen people coming back to the health facilities, but it does take incredible amount of time and effort from community health workers, but also from other sectors to support this. To answer also on your question about the missing deaths, we had a lot of discussions on this, especially after the ACAP's report, and did a lot of additional investigations, including over the last weeks. We just finalized more investigations actually today with the WHO colleagues together. We do think that it's likely there are some deaths hidden. There are incentives for refugees to not talk about deaths. there's always this fear that if community health workers know about deaths, it may be reported to authorities, meaning you get cut off from your food ration, you lose entitlements to the facilities. We quite strictly delink the two. We say the data that we collect are health data. They are not shared with authorities as personalized data. We of course share numbers because they are important for reporting. But when we did a lot of discussions with sector partners, with CHWs, with CHW supervisors, and really people say you cannot hide huge amounts of mortalities in the camps. One thing we also have to recognize, the Rohingya community is a community that where rumors also could spread quite quickly. No, it's a camp and the rumor spreads like a wildfire. We have seen this in the initial phase especially. And I think this might also contribute to this perception of deaths. And maybe just on the last point, if you permit me, just to, in response to the modeling, Sean, and what you had mentioned on where the models didn't work out, I think we were in a situation that's unprecedented. And for us, even the models didn't work out. They were extremely helpful because they helped us prepare for a worst case scenario. We didn't really know what we have to prepare for. What is the bed capacity that we should scale up? And the models really helped us to decide this is the number of beds that we need as a minimum. Even we were clear we would never meet the maximum that's required, but also then to look at, okay, so we will not be able to accommodate everybody. Let's look at home-based care systems and how we can support mild, moderate, and even severe at home. So just to really emphasize, although it didn't play out, it was extremely useful for us to direct us and to guide all the partners here in how we can respond in this really difficult situation. Thank you.
Paul, if I just may very briefly talk about the deaths, because I just wanted to say that even though we may be missing some deaths, I mean, even though we are saying that you can't hide large numbers of deaths, this may sound like a contradiction. We are seeing huge increases in excess mortality in some countries. Across Europe, it's dramatic. And I think China went back and they looked at their data systems, and they actually went back and looked at the mortality, and they increased their numbers of deaths as well because people died at home. And people are dying not just from COVID, but they're dying from other diseases because they can't access those health services. So I want to be clear, what I was saying was that it's very difficult to hide large numbers of deaths associated with COVID-19, particularly in settings which are well managed, which are well documented, where there's good surveillance. But make no mistake, this is a very dangerous disease. This is a very deadly disease, and this is a controllable virus. That's the whole point, is if this were something where we had no tools, where we could actually, limit the amount of spread, if we had no tools that could actually prevent people from developing severe disease and dying, that would be a different story. But we have those tools right now. And so I think the emphasis and what we're working at now is to try to calibrate our response to ensure that we don't put COVID ahead of everything else. We have to make sure that we do this, that we make sure that other medical services, all medical services, are back online, and that we can get businesses open, we can get schools open, we can have babies born safely and vaccines delivered. And that's the calibration period that we are in right now. And countries are really showing us the way to do that. But we're learning, 10 months in, we still don't have all the answers. But how we respond to this, I think, is getting better. It's getting targeted. We have a long way to go. And not everyone is doing well, but there are reasons for that, which we know what those reasons are. So I just wanted to highlight that it is very dangerous. It remains very dangerous. And a 0.6% infection fatality ratio may not sound very much, but that's pretty high, incredibly high, much higher than influenza if it is allowed to spread. And it is very high as it increases with age. But we have tools in place, and you're hearing examples of the tools that are in place that are actually preventing spread and from saving lives.
No, well said, and it's important to emphasize that none of us, I think, here are talking about the issue of it not being deadly, and that everyone has to take this very seriously. I have two things. I want to move to Sean, but at the same time, Ryan, if you can put up the poll so that we can do a repoll. And Sean, there are a lot of questions, and I mean, thank you for everyone who've been sending them, because there are so many good questions that we're never going to get to, unfortunately. But Sean, I wanted to ask you something specifically about the stochastic effects of the transmission and super spreader events. And why do you think, for example, that we apparently have not seen or we're not aware of such events in some of these settings? And then how do you think there's too much emphasis put on are not? So over to you in the reproductive rate.
So that is a tough question. Yeah, so again, I think it comes down to these events may have happened, right, in some of these settings, and we may just not have seen them. It's really unclear at this point, and I think until we have good seroprevalence studies in some of these settings, we really just won't know. It's possible that it's, you know, a combination of a lot of events or a lot of things happening and combining in terms of you know, testing and severity rates and reporting rates and all these things that makes it look like these haven't happened, or maybe they truly haven't happened because of some of the measures that are in place. And I think this is something that is really hard to answer right now. As for the emphasis on R naught, like R naught is, and the reproductive numbers is critical for understanding how transmission occurs, right? And I think what you're alluding to is the emphasis on what it was initially coming out of studies from China, coming out of the US, and taking those estimates and applying them into these populations and assuming that these populations are highly dense and have less ability to implement control measures. And so we assume that transmission is going to be higher, R naught is going to be higher in these settings. And that may be the case. I think especially early on, we didn't really have an understanding of how different populations varied, particularly, you know, maybe in the outdoor setting, asymptomatic or pre-symptomatic individuals transmitting potentially less, children potentially transmitting less. So it's not necessarily that we've overemphasized it, it's just that we have really not had a good grasp of what it has been in many of these populations.
We're over, so I'm going to say thank you to all of you. So Altaf, Sandra, Sean, Maria, thank you. It's been very interesting. There's so much more to discuss, and there's so much more to learn. So I'm just going to end by mentioning that the next webinar will be 1 month from now, Wednesday, November 11th, and the title is, it relates to what we were just talking about with Sandra, which health services in humanitarian settings should we not provide during COVID-19? These are meant to be provocative, of course, these titles. It will be moderated by Professor Carl Blanchet, the Geneva Center of Humanitarian Studies. Thanks to our panelists, thanks to Reddy, and thanks to all of you who took the time to be here today. Much appreciated. Have a good rest of the day and evening. Bye.